over to you, Stephen. So you're going to give a bit of a background and intro, Rosie, after that. Stephen.
Thanks, Rachel. Can I hear me? Okay. Yeah. Yeah, so we've done a couple of pieces of work over the last few years about inequalities in access to planned hospital care, socio-economic inequalities, and describing the nature of the problem, trying to scale it somehow, thinking through what the possible causes and consequences are, and then more recently setting out how an ICB might develop a credible strategy to address the problem. One of the particular findings from the first report was that when we looked at inequalities over a pathway that ended with some form of planned surgery, hip surgery or cataract surgery, for example, the data seemed to suggest that the problem emerged at the point at which patients were referred into secondary care. Earlier parts of the pathway, inequities didn't seem to be present, or at least were being managed. But patients were being referred into secondary care at similar rates, but only a smaller proportion of people living in deprived areas were going on to have surgery. That's what the data seems to suggest. It was only tentative analysis from 4 pathways. And we speculated a little bit about why that might be the case, but we were definitely in the realms of speculation then. And it would be great, I thought, to get a good answer to that question, a better understanding of why it is that, having been referred, why some patients are more likely to go on to receive treatment and others don't. And those why questions, then analysis isn't great at answering those sorts of questions. If you've got hypotheses, you can test them, but you tend to be limited by your own imagination then. And what really you need to do is some qualitative research to understand what's really happening to patients in that point in the pathway. And so I was really pleased to hear that Rosie and her colleagues in the Black Country had done just that, and some qualitative research to try and understand the factors that were behind inequalities, particularly in the MSK pathway. And really looking forward to hearing you talk about it now, Rosie. I've heard it before, but I'm looking forward to hearing it again. Over to you.
Thanks very much, Stephen. Right, I shall just try and share my presentation. And can you let me know if you can see it?
Yeah, I can see it. It's not in presentation mode,
just
but we can
popping
see
it in. Yep, it's being a bit slow. Come on, computer. There we go. Cool. Thank you very much for the introduction. So I really don't like online presentations that much, because when I press the slide screen, all I can now see is the slide. And it's really disconcerting because you can't see anybody else and you're kind of talking to yourself in your dining room, but I will do the best job that I can. So my name is Rosie Smithson and I work for the Black Country ICB in a small team called the Healthier Futures Academy, and I'm a qualitative researcher by background. And as Steve said, this project came as a result of the strategy unit work, and we formed a small team together with my colleague Bruna Barbosa, who's also a qualitative research methods specialist, and an MSK clinical lead, Carolyn Casey, on the project. I was speaking to Rachel before about this, and I'm going to try not to talk too quick and just try and ram too much information in. Do let me know, Rachel, if I'm going too quick, and I will slow down. I'll try and speak for about 20-25 minutes and then stop for questions. So really, what was the starting point for this project? Today I'm going to talk a little bit about the starting point, then I'm going to move on to the results of the research, and then I'm going to talk about the recommendations. I'm not going to go too far into methodology just because I don't have time, but please do pick up any questions you might have for me on the methodology as in the questions. That would be absolutely fine. But as Stephen said, the analysis by the strategy unit was in socio-economic inequalities along 4 pathways. And in the ICB in the Black Country, we looked at the 4 pathways, and actually we found that our inequalities were most prevalent within the hip arthritis pathway, and in relation to hip replacement surgery, as Steve's analysis had shown. The other pathways actually didn't show such inequalities in terms of statistical significance. So when my boss at the time handed me this report and said, let's try and find out some of the reasons why these inequalities are happening, there was it wasn't clear at the beginning. I had to start going down into data and realizing that hip was actually the one to look at in the Black Country. So we could see in all of our 4 areas, that's Walsall, Wolverhampton, Sandwell and Dudley, this trend was present in terms of people from more deprived backgrounds being less likely to have hip replacement surgery. And it was statistically significant in Sandwell and Walsall. But we could also see a trend towards the more affluent patients also being more likely to have outpatients appointments. I think that was only statistically significant in one area, but that general trend was present. And as I said, we were asked to shed some light on why this might be occurring, particularly from the patient's understanding. And what I really want to get across in this slide is that I was talking to Rachel before about this. These projects take quite a long time, and actually this time that you're thinking about the scope of your project and the questions you want to ask is well used time. And this process probably took about 5 or 6 months, looking really in depth at the strategy unit report to understand it better. Also then looking at existing research and policy guidance out there to see, well, does this happen elsewhere? And actually, yes, it does. So we found nationally and internationally, there is this socioeconomic inequality or variation in relation to hip arthritis surgery. And actually that's been present for some 10 or 20 years. And actually some of that research also started to try and look at trends in relation to sex, ethnicity and age. So for example, females have more need of hip replacement surgery but are actually less likely to get it. But again, those studies didn't really look down at the reasons why that was occurring. So we then started thinking about, well, how do we unpick this? First off, we were not specialists in hip arthritis. So our clinical lead was really important here in terms of just understanding the pathway and the different stages that patients go through and the different types of journeys that they could have. And that variety then really thought, could variation happen at these different points? It told us where inequalities or variations might start to occur. And then we thought, well, really, we need to get the consultants on board with this. So the consultants are the ones making decisions about hip arthritis surgery. Let's have a conversation with them early doors about this report and the information that's come out, but also to try and scope their hypotheses of what was going on as well. So we tried several times and we did end up having a meeting with some consultants in both Sandwell and Walsall, but as is their job, they're very busy. Some turned up in scrubs. We didn't really get great attendance there. So that was a challenge with the research. And we also wanted to attempt some further analysis. So we thought, well, yes, we can see there's a deprivation trend here, but what about ethnicity? What about sex and gender and perhaps religion and other things? We wanted to try and look at the profile of patients at different stages in the pathway and in Sandwell and Walsall. And that was a big flop. We tried really hard to get data at the ICB level that we wouldn't need to do extra data sharing for. And we tried talking to our colleagues in the acutes as well. But apart from data sharing issues, there were also issues that actually the data just wasn't coded along the way with all the necessary demographics that we wanted to look at. And actually things like referrals to the OA department, to orthopedics, weren't necessarily categorized properly in terms of lower hip, lower limb, upper limb, etc. So these things were not easy to ascertain from the quantitative data that was out there. So that led to this focus on actually we need to understand the whole pathway, because we can see that more affluent patients are getting more outpatients appointments. So what's happening in the early stages of the pathway that might be making that happen? So we knew that it wasn't just about looking at decision making around surgery, which was some of my colleagues really wanted to focus on that at the beginning. I said, well, what about those people that don't even get to have a conversation about surgery, those people that have other barriers? So I managed to persuade that we would look at the whole pathway. We need quite a flexible, semi-structured interview method to do that. And where we did get to the point that people have had discussions around surgery, we really focused on that to try and understand what was going on. So just a wee little bit about our design of the project then. So the initial design, you always have an ideal, I think, in your mind about what you would like to do with these projects. And when you look at sort of homogeneous samples within qualitative research, often the research sort of guidance is around 12 interviews with each cohort. So I decided to try and get about 12 patients in both Sandwell and Walsall to make around 24, a mix of the most deprived and least deprived patients, so we could see what differences were going on there. We wanted to access these patients through secondary care and primary care lists, through professionals that were working with them. And we had a vision that at the end of the interviews, we would do workshops with patients, workshops with staff, presenting the results and looking towards what recommendations and changes would look like. And then we might try and bring patients and staff together. That was a big aspiration, I think. So we ended up having to amend our design. We had to access the patients actually through voluntary and community organisations, because when we talked to the research and development teams within the acutes who we would need to access the patients through, they categorised this project as a formal research project that would need to go through Health Research Authority application process. At the time, there was just myself working on the project, and I simply did not have the capacity to go through all of that process as well, and actually that not knowing with the time scale of approvals, etc. So we decided to change the recruitment methodology to the voluntary community sector. And that also meant that we weren't going to have a really exact link into patients that had surgery appointments. We couldn't necessarily home down on particular cohorts. We'd have to generally go to community and voluntary organisations and seek people out. So the final design, or the final project as it resulted, was that most of our patients came from the most deprived areas in Sandwell and Walsall. And actually we ended up interviewing 15 patients across both the geographies. And most of those were in Walsall. I think it was 11 in Walsall, 4 in Sandwell. And that was with the help of the Walsall Housing Group, who had social prescribers and other community connectors going out, and they managed to link us into patients quite effectively. So that was really valuable for the project. But because we weren't finding enough patients with hip arthritis, we also extended it to knee arthritis. The same trends in terms of knee replacement surgery are present in the Black Country, so we felt that was valid. But to add to the intelligence that we were gaining through patients, we then said, well, let's try and do some focus groups with advanced physios and first contact practitioners who work in primary care with MSK patients, to find out what patients say to them about their journey and how they experience working with patients, what they can tell us about the process, as quite an easy group, an opportunistic sample to bring on board, and actually loads of intelligence from them as well. And then we resulted in no co-production workshops for the time being. And partly that was because actually a lot of the people that we interviewed were in desperate amounts of pain. And some of them, actually, we had people signed up to do with the interview and they had to drop out just because their conditions got really too severe and had flare-ups, which was a great shame, but it demonstrates the challenges that these people are living with. And it's just to say, sort of in my ideal world as well, actually, for a kind of project like this, or an evaluation project where you're looking at a pathway, I would want to involve patients, but a whole range of different clinical staff, health staff, to understand their perspectives of the different parts of the journey. Because yes, you get the patient's perspective, and that is the thing that we were focusing on most. But actually, you then need to sound that out with professionals in terms of what might change, why is the reason why this is happening with patients. Bring that intelligence together so you've got both sides of the story, if you like. And that includes talking to the voluntary community sector as well. So we weren't able to do all of that within the project. Again, that's quite ambitious, but ideally we're trying to get that really holistic view. So as I said, I'm not going to go too much into methodology, but just to say that the interviews were in depth, between some were about 30 minutes, but that was quite the exception to the rule. Some were going on nearly 2 hours as well. So really in-depth conversations about people's pathway. We did digitally record them, so we had accurate transcripts to analyse through thematic analysis. So there's a lot of work basically that's gone on between this slide and the next slide that I'm about to show you. And you can ask me about that if you like within the questions. So there's a big challenge, I think, once you've done your qualitative analysis in your frameworks. You can imagine you've got lots of different tables looking at primary care and what's happened there, and the good experience and the bad experiences, and quotes and stories that have gone with it. How do you bring that all together into a coherent story, a coherent argument to communicate to other people? And it took me a while for the penny to drop with this one. I don't know why, but I then thought, well, actually, what people are all talking to us about is having a fragmented pathway. People talked about the fact that they went to primary care, they got some medicine, they may have got a physio referral, they may have got dismissed, they may have waited a few months, a few years, other things may have happened. They might have seen the physio a couple of times, they might have been discharged, they might have gone to secondary care, but it was quite a confusing journey. No one was pulling it together for them. They didn't necessarily understand all those different stages when they were in earlier stages of the journey. It was quite a confusing mess, if you like, for them, and they felt lost and drifted within this pathway. And some of them didn't have the resources that they needed to pull this together, and didn't have the awareness that they actually needed to take this active patient role within the pathway in order to effectively and successfully get through it. So that's what we found in terms of the framework for the findings came into this pathway analysis. And we looked at both organisational factors that could either be a pro, something that helped people through the pathway, or things that could be a barrier and a burden through the pathway for patients. And then on the patient side, again, there were factors that could help them through the pathway and things that might be a burden. And the mix of those two things together, along with the fragmented pathway, meant patients either had quite a smooth journey or quite a complex journey. I hope that makes sense. So we linked all the data into this argument. And what I'm going to present in the next two slides are some of the findings about these organisational and patient factors. And I'm going to present some quotes so you can see what the patient said. And alongside you looking at the quotes, I will talk about some of the findings. And I hope it's not too many words at once. So the first section we talked about in terms of these organisational and patient barriers were appointment bookings. And I can hear everybody probably say, yes, that ring truth to me. It's so hard to get through to my GP. I have to phone several times. I have to do it at 8 a.m. or 8:30, etc. All these things that we experience in terms of primary care access. So the patients talk about not being able to get through on the phone. I talked to one very elderly patient. She was about 85. She said, I had to fill this form in online. I was really slow at it. I'm not used to using a keyboard, etc. And then it basically said, ring your GP for an appointment. So she was kind of screened through this process. So it seemed quite cumbersome to her, and she didn't quite understand what was going on. I had one lady who had actually resorted to writing handwritten paper letters to her doctors because she simply wasn't getting through, and posting those to the GP practice. And she found they would respond to those. But I thought that was quite extraordinary that she had to take that step. So calling, just that barrier actually in terms of calling and making an appointment, put people off actively seeking help with their MSK and other issues. But quite a few of the patients also talked about not wanting to be a nuisance, not wanting to be a burden to the NHS, to limited resources. And there was this value set there, I think, potentially within more deprived communities, and that they saw it as a limited resource they didn't want to necessarily pull on until they really needed to. So some people were waiting until their conditions were really quite advanced to seek help from primary care. And then in terms of hospital appointments, there was a lot of phone appointments going on because we were in COVID, and patients were finding those quite difficult because they weren't necessarily running on time. They were missing the calls. They were coming from a private number. And sometimes if they weren't answering them successfully, they were discharged. So there was all those barriers around communications in secondary care and primary care around appointment bookings. Then in terms of primary care appointments, when the patients were there talking to their GPs about their MSK condition, some patients felt that their doctors really listened to them, really understood, really empathised, gave them extra time to talk about their condition, their MSK condition and related issues. and they're actually traveling quite some distances sometimes to stick with a GP that they really trusted and liked, and thought was compassionate and empathetic. But other patients really had to push, they said, to get their GP to listen. We had one patient who had fibromyalgia, and her GP kept on putting all of her pain down to that. She got some advice from another a voluntary sector colleague, actually, and they said, no, I think this sounds like hip arthritis to me. She went back and she pushed, and she was diagnosed. So that extra help from somebody else gave her the confidence to be able to do that. Our patients talked about 10-minute appointments and how difficult they are for people with MSK conditions, and often our patients had comorbidities, diabetes, asthma, some had cancer. There was a lot of things going on for these patients. So to talk about the MSK issue and all the other things that were going on, really couldn't be done within 10 minutes. And some people were literally told, your time is over, you've got to get out the appointment now. So they really had to prioritize what was their top medical issue at the moment, and in that medical issue, what particular thing were they going to try and take forward with their GP. And some of them had to push for referrals, and some were actually surprised that they got one. So the guy on the bottom quote there said, I think he almost didn't ask for a scan because he didn't think he would get it, but then he did get it when he asked, and he was relatively surprised that had happened. Bear with me. And so the other thing that was happening in primary care actually was GPs were, when they were referring on, they weren't referring on to triage and MSK physiotherapy colleagues, which is the process and the get it right first time pathway for OA hip arthritis. They were pushing them straight through to secondary care to get the expert view as they saw it from the consultants. And that was problematic in the fact that we all know how long referrals can take, and particularly now with COVID and the backlog, to actually get through to see secondary care. You have your imaging, you might get that on the same day, or might get it on a separate day, but you're waiting all the time, you're getting that. And actually, if they're not eligible for surgery, which I'll talk about in a moment, they hadn't got any help during that whole process, which could have been a year, could have been 2 years, waiting to get to that expert opinion. So that was really quite problematic. Then in terms of conservative management, I'm just going to show you a quick slide, sorry, on the next, is it there? Bear with me. Where's it gone? Here we go. This is a slide that our clinical expert showed to me partway through the project. And you can see there that on the bottom, you're talking about mild arthritis and the treatment that patients would have. That's mainly information, advice and guidance, weight loss. And then you move up to things like physiotherapy, different medications, occupational therapy, and then you move up again to joint replacement surgery. But this is showing us that actually of all the people that have arthritis, not all will go to surgery. Surgery is not the solution for everybody, which I know is a bit ironic because we're talking about inequalities in surgery, and I'll come back to that again. But patients weren't aware of that. That wasn't something in their mind. I think they were very much thinking, right, I need to get through to secondary care to see a consultant to see if I need surgery. All the other parts of the process were sort of being skipped. So the part that is important within there is the physiotherapy, and many did have physiotherapy referrals to try and do conservative management. And actually guidance says that patients must have had conservative management for at least 6 months to qualify for surgery. So it is really important that patients are doing this. But we have mixed experience in terms of physio again. Before COVID, we had one lady who, for example, who had like 6 sessions in a gym in one of the acutes. I think it was Samwell. She was really quite pleased with that. And then she was in the community, but that was much less connected. And I think she had 1 or 2 appointments. I think that's the largest period of treatment that I've heard about in terms of physio with our cohorts. Often it was just 1 or 2 appointments. And these people are finding doing their physio exercises very painful when they're doing them and very painful afterwards. But it was really important. And because they weren't having this interaction back with the physiotherapists to drum in why it's important and the improvements that it can make for their condition, they weren't necessarily doing it. Sometimes having that extra pain was concerning, so it put them off as well as the practicalities of doing it. So that was a gap. And we had one lady, for example, who said, this isn't going to do anything for me. I walk every day, and she just threw the exercises in the bin. She completely dismissed it, which was quite interesting. Many of our patients were on pain relief. I think they're probably all on pain relief. Some were on milder forms, like ibuprofen, paracetamol, but others were actually on daily morphine. So really on quite high level pain relief. And then others were looking towards getting steroid injections in their hip for the pain. And they were having to wait for those, finding they were potentially getting discharged because of long waits. And also, we had one lady, I think she was about 85 again. She could barely walk. And she was really worried about having a conversation with her GP about having the steroid injection because he had suggested that he would do it. He had already done her knee injection, and that didn't go very well. So she was really scared about having this hip injection by her GP. And she found out sort of through friends that you actually could have this done at the hospital. But her own value set didn't want to criticize as she saw it, her GP. So she had been sitting on this for at least 6 months when we interviewed her. And she just didn't know how to approach this with her GP. And she had quite high level health literacy. So that was quite interesting again. So in terms of getting into secondary care, the referrals and the communications around that were a big issue for our patients, our more vulnerable patients. They had long waits from the referral time through to actually getting their appointment. Sometimes they didn't get an appointment at all. And what many of them realised is that they had to chase. They had to chase and then things would happen. But some chased earlier than others. For example, we had one patient who was waiting 3 years in between two referral points. And his wife actually worked at the hospital as a healthcare assistant. It took 3 years for her to then go to the medical secretaries and chase it up. And he just didn't have the confidence to do these things himself. And it seems strange to me they would wait for such a long period of time. But that's me as somebody who's quite assertive and will advocate for myself. These people didn't, they left it for a long time. So they found actually getting those appointments was quite problematic. Draining, it was really affecting people's mental health. That wait, that void, they were kind of waiting for something to happen. They weren't having potentially any other support in between, and their pain was increasing. So that was really quite distressing for patients, and it was impacting on both them and their families' mental health. And there was quite a lack of patient choice in there. We had one patient who worked for a supermarket, and he said, I understand how the NHS works because I know how our supermarket works, all the different departments, etc. So I know I have to get to the people who control these things to make it happen. And then he started thinking about his options in terms of travel and getting to the hospital with the shortest waiting list. But he was quite an exception to the rule in terms of understanding things and trying to push forward. I think I probably need to hurry up a little bit. I'm sorry. So then we had the orthopedics decision making. So once patients actually got to having those conversations, certain things were happening. So patients often talked about consultants discussing with them the severity of their hip arthritis, and sometimes that was really simple. The consultant was basically saying, "This is bone on bone. You need to have this surgery, otherwise you're going to seize up." So there's sort of no quibbles about it. But for other people, they were told, well, actually, yes, you have got hip arthritis, but you're not ready for it yet. We need to wait for it to progress. Come back when you're older. And they were like, well, how long do I have to wait? You know, they were discharged, didn't know what signs to look out for, how to get back into the process, when they might be eligible for surgery. So they talked about having to just live in pain, being left in pain, which was, really distressing for them. Then other patients had a higher BMI, and they were told they couldn't have surgery because of that. There was one particular guy who was on steroids, and this had increased his appetite for other conditions that he had. And he was discharged. He had one dietitian appointment, and that's all the help that he had to try and reduce his BMI to get back into surgery. But he wasn't told by his consultant how much weight he needs to lose, how he'd get back into the process, and he had that one dietitian appointment. And then several years later, he's then waiting to get re-referred and waiting for a new appointment. So you can see how people go round and round. And we know that BMI is higher, there's high levels of obesity within our more deprived communities as well. And this proved to be a barrier for quite a few people. Then I missed a bit there. It's about the communications by orthopedics consultants as well. We had some patients who were raving about their consultants, and he got the X-ray up. He did, it sounded like proper shared decision making. We talked about what kind of operation I should have so I could go back to work. But other people were just bamboozled. They said, I didn't get the explanation. I didn't understand it. You really need to help me here, write notes so that I can take away what I need to know. Then in terms of the decision making on the patient side, well, this again was a bit more straightforward really. A lot of them said, you know, I'm in so much pain, I've got to have this surgery. Yes, I'm worried about it. It's complex surgery, but I'm going to have it anyway. People talked about their finances and having enough support. And there was one guy who was living in a van when he was first told he needed hip arthritis surgery. And of course, he couldn't recuperate when he was living in a van. He then moved to a flat because that's the only place he could get in social housing. Again, flights of stairs, couldn't recuperate there. So his social prescriber managed to get him into a bungalow. So you can see all the barriers that he experienced, the help that he needed along the way to actually get to a place where he could have the surgery. So I just wanted to briefly emphasize that those barriers and things that I've talked about, some of us might say, yeah, that rings true to me. I experience those kind of things. But I want you to remember all the different things that are going on for these patients, these more vulnerable patients, that make dealing with those things, overcoming them and self-managing them much harder than it might be for somebody who isn't in this kind of lived environment. I can see that I've not got much time left, so I'm going to whiz through some of these recommendations and I can send the slides round at the end anyway for everybody. So I hope that you'll see that the recommendations that we've made are clearly related to what the patients told us, but they also link in with what we heard in the focus groups from the physiotherapists, and they also link into transformation guidance and things that I found around OA pathway and things myself. So we talked about actually, you know, I talked about the fact the patients went straight to secondary care and not to the triage that they should have done. So we talked about the fact that FCP appointments, these first contact practitioner appointments in primary care, needed to be much more consistent. GPs and receptionists need to be passing MSK patients through to there to make sure they're doing this conservative management first. And they need to be seen as MSK specialists in primary care, that you don't need to go straight to secondary care to get that. It won't shock you to hear that we think they should have longer appointments to understand their MSK issue and how it interacts with other health issues. They need longer than 10 minutes. These are quite often middle-aged to elderly patients. They've got lots of comorbidities. They need time. And that also presents an opportunity to do awareness raising and conservative management and other bits of education. At the moment, there aren't regular reviews for MSK, for OA hip, sorry, within primary care. So for things like diabetes, you would get regular checks to see how you're doing. So we're suggesting that this should happen for MSK, and it's actually, I think, in one of the guidance documents. And that would enable a point where patients that felt they were drifting could talk to primary care about what was going on, about overcoming some of those hurdles. And I didn't mention this there, I forgot to, but their medication wasn't very effective quite often. And I think with OA hip, it's never going to completely drown out the immense pain these people are in, but perhaps this could have been improved if they had medication reviews, which they didn't seem to be doing. And patients said, well, actually, I didn't raise it because I think I'm on the highest dose anyway. Then they're just going to tell me that, or they're just going to try to put me on more medication. So I don't want that. So they were making assumptions about what would happen rather than having that discussion. And GPs weren't actively raising that discussion with them. To actively have those regular reviews in primary care, you actually need to have an OA register for hip patients, which isn't present at the moment. So we're suggesting that should be introduced as well. Alongside that, we're saying, well, actually, because of this fragmented journey, someone needs to help coordinate this pathway for these patients and to overcome some of those barriers that we've talked about. So yes, those appointments we've got on the left-hand side will do some of that, but actually some of these very vulnerable patients need a bit of hand-holding through the process. We're all familiar with the R's roles and health coaches and things within primary care at the moment. Those individuals might not have all the skill set that they need to support people through the complex MSK pathway, but those advanced physio practitioners, the FCPs, will do. And we're not saying exactly where this support should come from, because we know that every place is different, every setup is different, but we're suggesting that there should be personalised support, giving these kind of things, shared decision making, surgery education, overcoming barriers with surgery, having shared care plans so they know what they're doing, what secondary care are doing, what primary care are doing. Things like preparing for secondary care appointments. They wait so long for that appointment and then don't necessarily know what questions to ask, what information to take away, etc. So and then all the things with weight loss and managing physio, etc. in that personalised support. And this is the last slide. then we talked a bit about improving those communications within the orthopaedic consultants. Consultants are very much fixed on, is this patient a eligible person for surgery, which is quite right, that's their job. But patients weren't taking away all the information they needed to. So actually having visual aids, writing things down for people, having contact printouts that you can easily hand over would be really helpful. But also maybe having a debrief with patients as they leave appointments. Having been in orthopaedic clinics myself, I know that when I come out, there's lots of orthopaedic nurses there. Do they have the capacity to just do a quick debrief with that patient to say, do they know what's happening next? And one of the really important things actually is having access to both face-to-face physical appointments as well as virtual, because our patients are sometimes saying, well, I haven't seen the consultant for ages and they can't see how swollen my legs are. How do I get this across? And our FCP, our physiotherapy colleagues, thought that more affluent patients with more health literacy will be able to communicate those kind of things more accurately or successfully over the phone. And again, so they were getting further ahead. In terms of that surgery decision making, more shared decision making and more awareness raising of patient choice, I think needs to be in there. In the Black Country, we're just introducing a harmonised policy around BMI and surgery. And actually, this is going to mean that it's harder for patients in some areas in Sandwell to get surgery. They're going to have to go through an extra process. I'm predicting that will be harder because other research has shown that is the case. So that for us is like, why are we doing that? Because actually, we already know that patients from more deprived backgrounds have more levels of obesity and are facing these issues. And we have tried to push that up. Into with our medical colleagues. Then those conversations around age and severity need to be more clear for patients. And we felt that it's important just to make sure that consultants are talking to patients about their future aspirations. Some of our patients had quite small worlds, I see. They got shrunk quite small. They had to stop work because of their pain and other comorbidities. They weren't getting out as much as they could have done. You know, they had quite small social and other worlds going on. That doesn't mean they don't want to have bigger social and other worlds. So think about patients' aspirations as well as what they're currently doing, and if they need hip surgery to carry on playing golf, which is the example my colleague always gives to me. And then we thought, well, actually, maybe we need to review surgery measurements as well, what outcomes our consultants are being judged against, and whether or not there could be more information in there, more criteria to encourage consultants to work with more vulnerable patients, and whether or not they're being reimbursed adequately for the complexity of surgery with more complex patients vis-a-vis the more straightforward patients that might be from more affluent backgrounds. So I am now going to pause. I hope that was okay. It was quite a whistle-stop tour of the whole project. Probably quite a lot to take in.
Thank you, Rosie. No, that was fascinating. As we were talking about beforehand, it's just really I don't know the word, but it was extremely positive to see the fact that we have produced an analytical report back in 2021. So Stephen's report on the inequities in access to elective care was back in 2021. And we talked about how long this process can take to actually translate evidence into sort of actions, and we're not there yet.
Well, no, the bit I forgot to mention actually is that we are heavily in dissemination now. So I am doing this presentation a lot in slightly different ways to different groups, trying to push the message out, but that is a big challenge.
Okay. And I've got a couple of slides because I said to you, what would you like to ask the audience? And you gave me a couple of questions. We can come on to those in a second or two. So thank you very much for describing the project and that sort of fascinating insight into those individuals and how their experience of that pathway. So we've had a couple of comments, sort of general comments, and then we can just, I think we've got plenty of time, Rosie, to move on to to move on to those couple of questions where people are going to help you to have an impact with this research. So let's just share my slide. Here we go. So there's just been a couple of comments on here. So I'm showing my slide so you can. It's two ways to do this, Rosie. There always is. Either I pick on one and suggest you respond to it, or do you just pick one or two of these comments and respond to them yourself?
So let's just go with the first one. So what does that say?
Okay,
Interested
that's
in the
easiest.
question. I don't know if the person who wrote it wants to say it, so I understand it in totality.
I will invite the person who typed this to, if they are able,
if you've got the confidence. So interested in the question, challenge of whether something is an order. Oh, right. Being sat in an acute doing quant analysis, we would assume service evaluation. Yes. So what was the project defined as in terms of research, etc.? So for me, yeah, this is a difficult one because you could argue it kind of either way. I mean, is this new knowledge? Is it evaluation? I mean, I think it is an evaluation of a pathway and it's patients' feedback. And we do this all the time through feedback forms, etc. So if we always see those kind of quality, this is in essence a bit of a quality assurance process, isn't it? It's about improvement. For me, these kind of projects is always about improvement. It's not about gaining intelligence. That's the so what do we do with it? What can we change? So when you look at those definitions that HRA have, actually I do think this falls into evaluation. There's also one that says, I think, business as usual, which has sort of quality assurance underneath it. But if you wanted to go for academic articles and those types of things and push this out, then I think you probably need to try and badge it as research. But yeah, it's a constant sort of headache if I'm being honest, because you just want to get on with it. And we also had to do obviously the data protection impact assessments for the project, which was fine. You know, like you have to do these things. It's really important. It makes you think for a lot of the project stages as well. But we also had to do, because our first project, for our transcription service and procure our transcription. So there was a lot of infrastructure development we had to do for the project as well. Complex journey when not reflecting. Take-home mobility sounds expensive and risky. Both things we want to reduce. So great evidence here. Yeah, I'm not quite sure of the question, but MSK is like, Caroline's here, my clinical expert there with it. Yeah, she's giving us away. Is one of the most common reasons people go to their GPs, and it's one of the most common reasons people are off work. So in terms of the economy and the contribution they would make if we could support these patients, vulnerable patients, back into more active lives, so they're not pulling on services so much, etc. You know, yes, I think that's maybe what you're getting at there. It would be money well spent. And just from a ethical, humane point perspective, and Carolyn will see this too, some of these patients could barely walk. They were barely doing anything with in their lives, because they were in this catch-22 quite often when obesity was the issue, that they couldn't be they weren't mobile because of the pain of their hip arthritis, so they couldn't lose weight by being active. And actually research has shown when people have a BMI of plus 40, they're much less likely to be able to lose the amount of weight they need to get down to that surgery criteria at the moment. So again, we had one lady who just said, this is discrimination. This is discrimination against me because I'm obese. And she was very articulate and very stressed and frustrated about the situation. Are there networks of qual research analysis in health and social care? Good question. Are you suggesting dissemination to that group?
So I don't know, but I don't know whether the person who's if people do want to talk, then they and sort of with their questions, then please do. Well, I can say from my perspective that there are qual researchers and analysts in the Midlands Analyst Network. That's all I know. I don't know whether they're, and I think there are most likely to be sort of separate other networks that I don't know about. Carolyn, yeah. Carolyn's got a hand up. Carolyn's going to talk to us.
Hi, I just wanted to add to the previous question, actually. Okay. So about the economic implications. So I think both things are true. So I think there's a massive amount of unmet need, which, because it isn't on a disease register, isn't counted, doesn't scare anybody. But there's a huge amount of suffering, disability, and that is much worse in the deprived populations. On a positive note, I think many of the risk factors for musculoskeletal problems are also very relevant for other comorbidities. So you would get a bigger bang than your buck, if you like. So, you know, things like being more active, getting better sleep, all of that kind of, you know, stopping smoking, having a healthy diet, all of those things which would help arthritis would also help some of the other conditions. So and to the previous question, I think it was some elements of audit and some elements of service evaluation and some elements of research, which was because we were set a particular task really in responding to your report. So what we can tell you is, if it was just looked at from the point of view of an audit, no, we're not doing what, for example, the NICE guidance says we should be doing. We're not. In terms of service evaluation, you know, it is and slash research, it is new knowledge in that we are, you know, we've reported our patients' experience of barriers in a deprived population and in a multicultural population that there's a very little documented evidence supporting. So you know, there are elements of all really, and if the purpose of this was to create a publishable project, then we would have set it up differently. What we had to do was work within the constraints that we'd got in responding to your report. So those are my thoughts on what Rosie's just said.
I mean, aside to that, actually during the project, my colleague Bruno, I don't know if he's online, found some guidance that the NHS has done around expert patient experience programs, I think. So what we basically done, taken patients' experiences, investigated those and generated solutions. And actually it says in that document that you do not need HRA and ethical applications to do that kind. So in the future, I would be badging it as patient expert experience, I think. And as part of that, you can bring in professionals as well under the same banner.
It's easier to say no, though, than work with a DPIA and a different organisation, you know, and so it was very difficult for us to get this, to take this forward, because it's easier for people whose only perspective is ethics to just say no.
Absolutely. So yeah, you live and learn, don't you? You live and learn. So next time you maybe
I did actually, my initial proposal, it was called an evaluation, but that wasn't accepted.
Okay. Okay, well, thanks very much for that, and thanks, Carolyn. I think we've got time just for if there's any, maybe pick one of the point or question that
I'd need to look at that link in terms of future. I haven't seen that, I don't think. Step 9, quality count. Oh, right, interesting. So 9 steps to making qualitative data counts. I'll have a look at that, thank you, afterwards.
Yeah, I did just have a quick look at it, and I suppose one thing is I think it's only available to NHS staff because it's future NHS, but yeah, it looks interesting.
No, so we did do consent forms. In our consent forms, you know, we did do, I used to be the ethics advisor in social care for Birmingham City Council, for example, so I know all these processes. So we did it properly, all the consent was there. So actually we can write a research paper on it if the journal that we applied to accepted it without HRA ethics, which is a question. I'm sure we could probably get into some professional journals, Carolyn, to push this out, and maybe some blogs and things. I think it's something worthwhile. But in terms of the ICB, we've been disseminating through the Clinical Learning Network. We're talking to the clinical leadership groups. That's the very senior folk in September. We're trying to talk to the orthopaedics and physios in both of the localities that we did the research in, as well as the other 2 places. And I'm pushing it out through the Chief Medical Officer's office as well. So we're trying to, and I'm trying to get to the Primary Care Collaborative. But you can see within a complex system like the ICB, and that you will see the recommendations span primary and secondary care. There's so many places to go to with this. It's a challenge.
Yeah, and a coordinated response is very difficult as well, so that you can see people might be able to pick out specific parts of the recommendations, but what you need is a holistic change to the whole pathway and for it to be the fragmentation to be sort of meshed and for it to be sort of coherent.
I think one of the issues will be that people will listen to this and say, actually, that pathway is also fragmented, and so is that one. And it will be also, why do we prioritise the MSK if we prioritise MSK? And I think the economic arguments and things are there.
But I'm not sure whether we've signed.
Yes, indeed. So we do have not that much time left, actually, Rosie, but I think we could talk for a long time, and I think your sort of the efforts to turn this evidence, this insight into action, which is what this is all about, to have an impact is something that we're all trying to do. We all want. Else, what is the point of producing analysis? What is the point of providing evidence and doing the work and learning if you're not going to do something with it. So you did ask me sort of a couple of questions to ask people, so I haven't got time to actually invite people to respond. One of them was, I have on the screen now, am I still showing my screen? Useful, dead useful if I was. Was what would other people do with this type of project? So that was one of the questions that you have. So I won't ask people to respond to that now. And then of course there's this, what would you do with it? You know, what you, I can see all the things you're trying to do and reaching out to all the people that it affects, all the people who will be able to have able to use it and have an impact. And so what would others do? Have they got any other great ideas? So no doubt insightful audience will let us know. Could be after the session today, I suspect, though.
Yeah, please feel free to get in contact with me. I'll send around the slides, and my email was obviously on the system, so I'm open to advice and things. Thank you.
Thank you, Rosie. Thank you, Carolyn, for contributing as well. Okay, I've just got a couple of seconds left to just say briefly about what is coming up in the next few huddles. So we have the National Competency Framework with Andy Lavelle and Sarah Brundell. That's in a couple of huddles. And we've got these other ones coming as well. So community service contracts, supply, equity and impact. And that's with Strategy Unit Andrew Jones. The need, demand and supply of general practice consultations. That's with Stephen Wyatt. We've actually got quite a lot of everything booked in, so we haven't got many gaps coming up at the moment. So let's look forward to those, and just a brief look at what is available quite soon in terms of training and development. So like I mentioned before, these are coming up largely in September, October, but it's just around the corner, and people are already planning those training sessions for when they come back from leave, and they are basically going quite fast. So please, if you are interested in registering for any of these, go to the website and just get registering for these courses, which are coming up relatively soon. So as always, if you've got any questions about today or comments, just get in contact with me. I'll just stop sharing my screen. I will say thank you again to Rosie, Carolyn and everybody who came today and for your contributions. And the recording for this will be on our website if you want to go back and review how brilliant you did, Rosie. So I will say goodbye to everybody. Enjoy the rest of your day, and I'll see everybody in a couple of weeks.
Thanks, Rachel.
So, okay, bye everyone. Bye, Carolyn.